Thank you, sir. All right, this one you can just give to them.
Right, guys. Next, we have a returning presenter, an authority in his industry, with a presentation on understanding the value of regenerative medicine in modern healthcare. Please put your hands together for Prof Dr Ramamurthy Subramaniam. He is the CEO of International Institute of Wellness and Aesthetic Medicine. Please put your hands together. Feet together. Yeah. Thank you.
Thank you.
All yours, sir.
Hi, good morning, everyone. Okay, just skip this. Always happens. Okay, thank you. The next, okay, good. Now, let me get straight to the point. I started aesthetics back in 1999, all right? And over the years, I realized that aesthetic has shifted out of the paradigm and people are going into wellness and longevity, which is good. In my humble opinion, I feel that wellness and longevity medicine will overtake a lot of industries, all right? If you read the facts here, you'll understand for yourself. But the question here is, in Malaysia, we have the so-called LCP committee, which I enacted back in 2004 to regulate aesthetic medicine. One simple question for you to think about when you go back home later today: who is regulating wellness medicine? Who is regulating longevity science? In other words, who is regulating stem cell? Who is regulating so-called NAD infusions? You know, we had a patient yesterday who came to us saying that his vitamin D was very low. He went to a clinic and they gave him 300,000 of IV infusion of vitamin D, and now he can hardly walk and move because his bones and joints are stiff. Is that what we are supposed to do? Regen medicine, my idea today to be here is not to share with you how to do it, is to share with you the limits of regen medicine and the ethical code behind that, which is the most important thing as being doctors. As doctors, our first rule of Hippocratic Oath is do no harm. Regen medicine is fantastic. Trust me. We made autism child back to normal. We made stroke patients walk. We made Parkinson and Alzheimer's patients remember their family members. But again and again, are we over-promising results? Are we delivering what we are supposed to do? That's one. Second, the demarcation. Who can do, who cannot do? Can beauticians do NAD? Of course not. Can doctors do NAD? Maybe. But which category? What is the training? What is the background? That is what we are here to discuss about the stakeholders of the industry. Okay? Now, cost. Okay, can't point there. Cost. Imagine a stroke patient. Okay? What do you think a patient, age of 40 years old, got a hemiparesis stroke, and is not able to walk anymore? Its maintenance cost for the next 20 years. I'll show you a slide where scientists are able to reverse stroke using iPSC. All right, I'll show you the slide soon. So the cost factor affects a lot. But my other area here is rebellious activity. Will people go against it? Do you know in the world right now who's against stem cell and regen medicine? Any idea? Perfect. Beautiful. Thank you. Pharma companies. Because that's their bread and butter. We are robbing them of their income, but we are giving back to society what is needed to. Pharma companies are the biggest rebellious agents. Most of the clinical papers, when you dig and dig and dig, you realize that the ones who say that no are pharma companies. I'll show you some slides to understand better. Okay, regen medicine. Definition is quite straightforward. Therapies that restore tissue organ function. One is degenerative science, where we degenerate as aging goes by, natural apoptosis, phagocytosis. All that are fine. They're all perfectly good. That happens to everyone. Okay? But stem cell therapy, gene editing, biohacking, 3D bioprinting, exosomes. In my opinion, again, humbly, exosomes has been exploited. Use exosome. If you tell me I'm using exosome for wound management or chronic diabetic ulcer, I'll support you. If you tell me I'm going to use exosome for beautification, no, it's not going to work. It is not exosome that you're injecting below the skin. Trust me, I've been doing aesthetics almost 25, 27 years of my life. All right? Exosome in aesthetics is not going to work. What are exosomes? They are signal enhancers. They are paracrine signal enhancers. You are supposed to program exosomes so that when you give stem cells, they go to the brain or the liver or the renal or something else. Not to inject under the skin. But people are doing that. Why? Again, regulation, marketing, promotion, monetary gains. I'm not against monetary gains. We're all here to make a living. But ethical monetary gains versus other monetary gains, is that what we want to do? Stem cell therapy, uses of it. Yes, rejuvenation for wellness and longevity medicine. You got a lot of areas you can look into that. Stroke, post-myocardial infarct, spinal cord injury, traumatic brain injury, Parkinson, Alzheimer's, neurodegenerative conditions, chronic wound management, sexual health, autoimmune, autism, ADHD. Yes, we have treated. Okay, I'll be very honest with you, we have treated all these cases. Success rate, 70%. Not everyone will come out walking with a happy face. All right? So where does that go back to? Your selection. Your patient selection is the single most important thing. Your screening, your patient selection, your baseline investigation is the single most important thing. We'll come to that again in a short while. Okay, major drivers. What are the things that is driving regen medicine forward? There's good, there is bad. Good, of course, the breakthroughs. I made iPSC tech in red because iPSC, though it's not available in Asia yet, the closest we have come to iPSC is in Japan. And it is under clinical research. It is not for public use yet. So the next best option will be New York. You will have fantastic iPSC technology there. Programming, induced pluripotent stem cells, basically. That's what iPSC stands for. You're basically going to program cells, okay, to decide what they must develop. Meaning, a stroke patient, you do a neuronal stem cell, not mesenchymal stem cells. Okay? Mesenchymal stem cells mainly come from your umbilical cord, Wharton's jelly. I'm sure most of you know that. But what we are doing is, what they are doing is, they are using programming. They are programming iPSC to go straight to the brain. You got a renal failure in AKI, acute kidney injury. They are programming cells, iPSC, to go to the kidney. All right? I'll show you the power of iPSC in the next 2 slides. Okay. GMP system processing. You know? I'll share a simple joke with you. A couple of months ago, I went for a seminar in a conference, and then this chap came up to me and told me that I got some of the best stem cells in the world. I said, okay, fine. Do you have a certificate? He said, yes, I do. I said, can I see it? He showed me a certificate that says KKLIU. You know what this KKLIU stands for? Kementerian Kesihatan Lembaga Iklan Ubat. It is not justifying that it is stem cell. It is not justifying that their lab is fit to process stem cells. It just says that they got an advertising permission from KKM to say that they can advertise this particular product. You see? So now, coming back to this, the CGMP pathway. I don't know how many of you, ladies and gentlemen here, are dealing with stem cell medicine. Some of you who are may know that you buy from a lab, right? And the lab gives a certificate, right? Who prints the certificate? The lab. Authenticity. So that means I sell you so-called 100 million stem cells, mesenchymal stem cells, and I give you a certificate saying that it is 100 million stem cells. Is it authentic or not? You buy Botox, Dysport, you're buying it from probably Allergan, Zulik Pharma. Okay, you're buying it from a pharmaceutical company, which has been endorsed, checked, validated, approved by the ministry or NPRA. Here we are buying cells from an unknown stranger, and they will show you cells. So how do you validate that the cells are cells? That's your biggest challenge. It is not only in Malaysia, it's a worldwide problem. Every country I go to, I speak about this, I highlight this. So you must be empowered yourself with knowledge to be able to assess that this is MSC, the cells are viable, they are free from endotoxins, and the cell count. You must know the science behind how to do that. Unfortunately, in 20 minutes, I can't share that with you at this point of time, but probably next time we can. This is my favorite one. Sorry, regulatory pathways. Like I said, who regulates? I sell you 100 million. It can be 10 million. How do you know it's not 100 million? It's going to be a challenge for you. Same thing, economic pressures. Like I said, pharma companies are the biggest challenges that we are facing right now. You compare a cause of a diabetic ulcer or a diabetic wound that is going to be amputated versus someone who can literally reverse amputation. It's not about the cause, it's about the quality of life. Walking with crutches and walking with your own 2 feet makes a world of a difference. Okay? That is what you're going to offer. But before you can offer that remedy, you must know what is it that you are going to inject. That is what I'm trying to get to. Okay. Patient selection. Okay. iPSC. These are actual clinical papers. Type 1 diabetics, cured. HIV, cured. The first case was reported in 1997, not mistaken. Okay? It's called the Berlin patient, patient 0, the Berlin patient. Okay? Now, there is this, it's a very unique case here, one potentially treated of HIV. You see, to use stem cells to treat HIV, this was an accident. They didn't design it. The patient had HIV and had some blood malignancy. So they're trying to help her by giving her stem cells. And when they did the stem cells, they realized that her retroviral count reduced, her CD4, CD7 all reduced, and she recovered. Not only recovered, she cured. She was cured. No more antiretroviral drugs. She was literally cured of HIV. And then they realized that the stem cell they gave her had a genetic abnormality. It's called CPSR5. CPSR5 is a genetic abnormality. And the reason why I'm highlighting this in iPSC is, I'll come to that shortly, okay? See, CPSR5 genetic abnormality exists in 2% of the world population, point one. Point two, this 2% of the women in the world population must be pregnant. And they must be willing to donate their umbilical cord. Only then you can do it. That is a normal pathway. But iPSC technology, induced pluripotent stem cell technology, is now reversing that genetic problem to create an anomaly and induce it to treat HIV. So, this is one case. Woman has been cured of HIV. Now, come back to cost. HIV, antiretroviral drug cost for 1 year versus 1 session of stem cell medicine versus the possibility of quality of life. This is the one I was talking to you about earlier. Scientists reverse stroke damage, okay, with stem cells. 2025, September 16, recent, okay, University of Zurich. Okay. Interestingly, what they did was, again, iPSC, they induced stroke in mice, they injected, and the neuronal cells regenerated. Okay. So a lot of pros and cons behind it. The challenge with stroke is, there's a window frame as to how fast you must treat it. But hospitals do not allow you to go and do stem cells with them. In Malaysia anyway, all right? And you are stuck in a limbo between being able to administer and not being able to administer stem cells. So, what are the key technologies that allows you? CRISPR. It's been a fantastic breakthrough for CRISPR. Gene editing, basically. You are using bacteria and technology to do gene editing, okay? And tons of medical conditions are being cured. I'm not talking about treatment, I'm talking about cure right now. So, CRISP, palindromers, okay? They're fantastic. We're using bacterial studies. We met with a scientist from University of Tokyo who came in. They're using viruses to carry stem cells to the targeted organ. You see? So what I'm trying to highlight to you here is regen medicine is not as simple as just like, okay, I buy stem cell, I inject stem cells, you walk and go. And of course, you swipe your credit card in between. That's not the idea. All right? The whole story here is how are you going to do stem cells medicine or regen medicine? Okay? These are the potential areas. Okay, potential. Now, the reason why I'm emphasizing the word potential is we are a member of the International Society of Stem Cell Research. Being a member with that particular society, you are bound by a lot of rules and regulations, okay? Which means you cannot make any promises. They have 3 biblical rules in their guidebook. Number 1, if you do stem cell for someone, he or she is your responsibility for the rest of their life. Okay? Number 2, do not promise. Number 3, disclaimer. What is a disclaimer about? Malignancy. So let me ask you a question. Can stem cell provoke cancer in a patient? Something for you to think about. There are a lot of studies. You look into 100 papers, 50 papers will say no, 50 papers will say yes. Right? So that's why whenever people ask me what is the first thing you do, I say tumor markers, CTCs, as well as family history of malignancy. These are your key baseline investigation that you need to do if you are planning to do regen medicine. Even CRISPR, gene editing, anything that you do, you're going to alter the blueprint of a human being. You need to do the baseline investigation, without which you should not proceed. Okay? So you got ortho, you got cardio, you got neuro, diabetics, islet cell replacement. Okay? The islet cell replacement is a very fantastic story as well. There was his dad was working in NYSCF, New York Stem Cell Array Foundation. That's why NYSCF stands for. His son had type 1 diabetics, and of course, type 1 diabetics, insulin and whatnot throughout the life. Cost is one issue, quality of life is another issue. Okay? So when the son had that, the dad vowed himself that he will find a solution. So what they did was they programmed, they used iPSC, they had access to the technology. Okay? So they accessed the technology, they programmed stem cells to be what? To be islets of Langerhans. So we are no longer going to the future of organ transplant. All right? Organ transplant is long gone. We are going into the future of medicine where we're doing cell-to-cell transplant, tissue-to-tissue transplant. Okay, we're no longer going to cardiac renal transplant. No, we're going to cell transplant. As long as there's still some amount of viability. Okay, that's what we are going to. So that's where islets came in. Of course, ophthalmology, retinal repair, AMDs, wound care, pediatric, autism. We have managed a significant case of autism, and their attention span improves, their behavioral pattern improves, their focus improves. Can you imagine a child, or can you imagine the trauma the parents go through, seeing their child cannot mix around with the other children, their childs are aggressive, pulling hairs and jumping and biting each other off. But when you put them on, and trust me, just to share with you a protocol for autism. Autism is not all about stem cells. It's about gut therapy, hyperbaric oxygen, and stem cell therapy. It's a combination. It's not just one, because it's that's why it's not called autism any longer. It's called ASD, autism spectrum disorder. There are multiple conditions that they are exhibiting, and it's a result of multiple things that's happening in their body that we overlook. Most people say, okay, autism stands for behavioral therapy. They are doing therapy and they're not doing repair. That's what I'm trying to highlight to you. Okay. So, autoimmune, endocrine disorders. There's a lot that you can do. Trust me, there's a lot that you can do with regen medicine. Please don't think I'm just focusing on stem cells. I'm talking about regen medicine. When we talk about regen medicine, it's not just exosomes or biohacking. It also involves what we call longevity technology. Okay? Technology that helps in wellness medicine. Next 1 to 5 years, what are you looking at for improvement. Growth in cellular therapies. I'm sure you can see day in, day out that more and more labs are coming up with cellular therapy treatments. Okay? Everyone wants to start a lab. You know, when we do umbilical cord, you know how we do it? You know how much we pay the parents or the patient for the umbilical cord? Any idea? 0. We are not supposed to pay them a single cent. We're not supposed to pay them a single cent. It's a donor. You're not supposed to pay a donor. All right? The protocol is simple. When someone wants to be a donor for umbilical cord for stem cell medicine, we are supposed to do a couple of screenings. Supposed to be elective cesarean section, not emergency or vaginal delivery. Elective. The team will be in the OT during the surgery. They remove the umbilical cord. 10 centimeters away from the baby's part of the umbilical cord is what is extracted, frozen for minus 240 degrees Celsius, kept in nitrogen cryotherapy. So there's a lot of process there. Okay? So the cost of the lab is the lab, not the cost of the umbilical cord. The umbilical cord is FOC. But that's why more and more people are jumping into cellular therapy because it's a garden of income for them. Exosome secretomes. Again, like I said, exosome secretomes has been exploited. If we use exosomes for wound management, trust me, you will get fantastic results. Early stages. You can save the limb. You can imagine a person, I'm sure you have seen diabetic ulcers, people without legs and whatever not, amputated. But if you can save the limb, it's a blessing for you. Exosomes does that. But where do we use exosomes nowadays? Leg or face? Exactly. Who does that? Who pushes us there? The companies. See? The other day I had a doctor who came to me and said, Prof, I used this particular laser machine and I burned the face. I said, why did you do the setting? Oh, the salesperson told me to use the setting. So who was your lecturer? Salesperson. So same thing here. Okay. GMP manufacturing and supply chains. It's a very huge topic. Got less than 7 minutes. I'm not going to go into that right now. Yes, this one, regulatory, ethical landscape. Regulatory is the biggest challenge. Most countries are not equipped with the required technology to verify stem cells. Okay? The viability of stem cells, the count of the stem cells, okay? The movement, the passage. You got, see, the labs that do passage 1 to 4. Passage means you culture, you move to the next petri dish, you culture, you push the next petri dish. That's called passage. Okay? So passage, you got passage 1, 2, and 3. Now there are labs that do hypoxic culturing of stem cells. I know it's a bit too technical, I'm sorry for that. Hypoxic culturing, that means they grow stem cells in a very hypoxic environment. And they got modular chambers. Okay? It's another science of stem cells. So when you do hypoxic culturing, they go up to passage 24 or 25. That means they pass through 24, 25 times. Now, one school of thoughts will tell you, passage 1 is very immature cells. Passage 3 will get matured cells and a good count. Passage 5, 6, and above, you get a lot of cell counts, but they are not viable cells. They are almost dying cells. They are old, aged cells. You see? So there's a lot of science behind all this passage 1, 2, 3, 4, up to 25. But the method of culturing it makes a difference. The reagent that you use, what kind of growth factors are you going to use? Your exosomes that you're getting from all these labs are basically the leftovers. Those days, we used to throw the leftover. That means I culture it, I only want the cells. The growth medium, I'll throw it away. But now, that growth medium is where your secretomes and exosomes are coming into picture. Okay? Okay, this one. Again, ethical landscape. Embryonic stem cell lawsuit. What happened here? You see, IVF, I'm sure you all know about IVF, right? So in IVF case, they have actually done something where IVF, what is viable, you keep, what is not viable, you discard. But there was this particular case in US again that they used IVF that were not viable and converted into stem cells. They are pluripotent, not multipotent. Pluripotent being from an amniotic source, they can become any cells. They are the most potent one. But ethically, we are not supposed to use that because we are killing a life. That's pluripotent, all right? So that's where this issue came up. So, last slide, I think. So, basically, you need to integrate regen medicine into the healthcare system, which, again, I feel will take some time because you are going to get challenges, right? Right now, everyone can just buy stem cell, buy exosomes, secretomes, and whatever now and do it. At least the Medical Device Authority, MDA, Dr. Murali and all and his team have done something good where they have done something akin to let's regulate hyperbaric chambers. Those days, anyone can buy a hyperbaric chamber. They just dump you into a chamber, they give you hyperbaric oxygen, and that's it. You're good. It is not that simple. Do you know hyperbaric chamber, the complications? Eardrum burst, pneumothorax, decompression sickness. There's a lot of science behind hyperbaric chambers as well. How many ATAs are you going to use? Duration, intervals. There's a lot of science behind that. Now they're regulated. Only medical doctors can have a hyperbaric chamber, and that's also an ACC or a hospital, not a clinic, which is good. I welcome that suggestion. So, if you're going to integrate regen medicine with healthcare system, you've got to look into the entire wellness ecosystem. Not just buy, charge, inject, and game over. It does not work that way. Right? I don't have the time to go through what each one about stem cell, exosomes, secretomes, regen, medical science, biohacking, nutritional gut health. There's a world of science behind that. What I'm trying to share with you is the future. Where is it heading to? Okay. Safety tracking. Like I mentioned to you, ISCR mentioned to us earlier, they came on record saying that if you do stem cell, that patient is responsible for the rest of your life and you must put in the consent form. Okay, so safety tracking. It's not only about the patient safety tracking of the cells. Good labs will have a GPS, temperature control, everything on the box they sent you. That means if they release it from the lab after they have brought it to room temperature in simple terms, you're using it, okay, it's ready to good to go. There's a control limit, the duration by when it should reach your lab or your clinic, and a duration by when you should inject it. Just to share a little bit more, what needle size you're using, what tube size you're using. Are the cells going to adhere to the tube? Are you using plastic or are you using glass? All this matters. That is the importance of regen medicine. It's not like giving a lidocaine injection, not as simple as that. Regen medicine is very complex. The only thing is the outcome. You do it right, you get fantastic results. You do it wrong, you get nothing. Okay? Training and credentialing. Okay? Training is going to be vital. A lot of people, like I said, are using stem cell, or regen medicine by the hook. They just take it and just do it. That is not how it is supposed to be. Please, I beg you guys. If you are going to do regen, I've seen patients who have burned up their entire life savings because of a stroke, and they trusted someone to do stem cells for them. They did it, nothing happened. All right? Because we do not know what was injected. Why we don't know? Because no regulation. All right? So please get it checked out. Challenges cause immune rejection. I had another case recently where a student of mine did stem cell in Johor and came back with a massive complication. What is the worst thing that can happen in stem cell medicine? I'm not talking about GVHD, graft versus host disease. Cytokine storm. Cytokine storm is the worst thing that can happen following a stem cell therapy. So you should understand the pathway. Why did someone get cytokine storm after stem cell medicine? Okay? We all think stem cells are super safe. No, it is not. Uneven global landscape. Every country has got different rules and regulations right now. It is no longer paracetamol 500 mg, whatever doses you're going to take is standard throughout the world. It is not so for regen medicine. Hype versus evidence. Some people think that stem cell is a snake oil that does every miracle. A blind guy can see, a guy who can't walk can walk. Yes and no, all right? So for clinicians like yourselves, be smart about it. Be ethical about it. And the key point, my last deck, regen medicine is fantastic. Trust me. When you see the family of a stroke patient thanking you for the fact that their partner is able to stand up and walk again, is an amazing feeling. All right? It does work, providing you are doing the right thing with the right product in the right way. If you are able to identify these particular factors, you've got it done right. All right? Costing, of course, is a luxurious environment. There's a lot of research going on to minimize the cost. Okay? But we'll get there. Governance trainings, I already spoken to you about that. Yes, that's basically, I got 0, 1, and 0 seconds, right? Thank you. Time's up. Thank you, ladies and gentlemen.
Well, ladies and gentlemen, sir, do you want to take some questions from anyone? No? Did you guys put up the QR code for that? Anybody wants to ask anything about regenerative medicine? Yes, fantastic, awesome. I'm coming right over to you.
Thank you, Prof, for your nice presentation. I'm a general practitioner. I'm practicing, I'm board certified in regenerative medicine for IIWAM. But I'm still in the doubt that how I can present myself because my practice is still under clinics, Act 586. So I want to change my center into wellness clinic. Is it advisable for you?
Sorry, you said you want to change your center to?
Wellness.
Wellness. Okay.
But I'm not doing aesthetic.
Okay.
100% wellness.
Doesn't matter. Like I said, there's no governance right now. Aesthetic is good governance within LCP and whatnot. Chapter 1, Chapter 2, Chapter 3. All right? Chapter 1 for general practitioners, 2 for physicians, 3 for surgeons. But for wellness, at this point of time, there's no rules and regulation. Okay? That is what makes it scary. You see? LCP, there are some rules and governance, but I wouldn't say it's very well regulated as well. I'll be the first to admit that. All right? But for wellness side, there's no governance there. So you can start anything you want to anytime. You will have 2 issues here. 1 is consent. 2 is insurance. Let's say you inject some wellness concoction. Okay? Let's say you give some glutathione or NADs or NMNs or something like that, and patient has got a reaction to that. Insurance will not cover you. All right? Now, how many doctors here who have done NADs have asked for consent? Good. If you ask for consent, well and good. But most doctors do not have a consent form for NAD. They have consent form for chemical pills. When you give a normal antibiotic injection or a tetanus injection to your patients, you do not ask for consent. Because why? It's simple. It's proven science. All these supplements and concoctions we are injecting are not proven science. See, glutathione and whitening, just sorry to deviate a little bit, glutathione and whitening drips. A lot of people say you use vitamin C, glutathione for whitening the skin, bleaching the skin, right? It's a worldwide, maybe in Asia, okay? Popular concoction. Let me ask you a question. If you think it is working, don't you think all of us here in this hall right now, today, here, will be the same skin color? Isn't it? It does not. The skin bleaching effects of glutathione is through a very complex inhibitor pathway, which is a side effect of glutathione. That is why you are actually injecting very high doses of glutathione to induce the side effect to get the bleaching effect. You see? So when something goes wrong, it is not covered. That is a challenge. You can do wellness anytime you want to. You can do it immediately when you go back home right now. But you have to be aware of consent and insurance liabilities. Everything will go smooth. But when there is a problem, that's when the whole heel comes down. Okay? Thank you. Anyone else?
Yeah, on the screen.
Okay, I think I just answered that.
Okay, all right then. Thank you so much, sir. Thank you, Prof. Thank you for that insightful, pretty new field of medicine, and you're an authority on that. Anybody wanting to ask personal questions, of course, you can always approach Prof and ask him. Thank you so much, sir. Thank you. All right, ladies and gentlemen, now moving on to the next presentation, or rather actually, the next one is going to be a forum. But before that, I would just like to inform the participants a little bit about the booths and kiosks that are outside. Well, the one that is right outside of our Hall 1, InnoQuest Pathology, of course, they're a large lab, and many doctors are familiar with them. They've got My Cyto Health, V Medical Health Services, Masa is there, and even a realty or real estate company, FLP Realty. You've got something interesting called Apoclar. They're partnering with Celcom DG, and they've got a VR experience going on outside. We also have Perdim, Pertubuhan Dr. Islam Malaysia, with a very interesting device for fall prevention. And they have Gene Junction is also outside for digital health portal, primarily on cloud clinic management. So just wanted to let you know that these kiosks are outside for the next 2 days. In case, just feel free to approach them.